Hello and welcome back to the AHF Podcast. I'm your host, Joe Schwab. This week we have part 2 of our AHF roundtable on moving from posterior approach to anterior approach while already in practice. My guests are Dr. Alex Sah and Dr. Michael Blankstein. This week we discuss their thoughts on revision surgery, and we learn what Mike has been right about and what he's been wrong about. Let's get back to our conversation.
You actually raise a really good question, Mike, which is, so where do things go from here? I mean, where does anterior approach go from here, or where does total hip arthroplasty go from here? What are the challenges we've left to conquer?
That's a great question, Joe. Things have gotten very good with the anterior approach, and I think as you see the movement to the ASCs, you see outpatient surgery. I think anterior really lends itself to those types of things. I think we can still get better in maybe even more minimally invasive surgery, fewer releases, potentially better wound healing with our incisions and how we manage the soft tissue. So I think there are still areas for improvement. Certainly we're seeing a large increase in revision surgery through the anterior approach. I think we're going to see more and more of that being developed. That's an area where probably tools and other techniques and other approaches will help us more as we learn how to do larger and more complicated revisions through the anterior approach. I think there's room for growth there.
So if you look again at the current day revision rates, according to the American Joint Replacement Registry, the 3 top reasons are infection, dislocations, and fracture. So obviously where we should continue to work, put all our effort is into preventing infection, or again, optimizing our patients better. So if you had to choose one, I would say better patient selection optimization. In terms of periprosthetic fractures, we have gone a long way, and this is my little plug for knowing how to cement a total hip when necessary. But there's some really good data showing that maybe these modern stems, these brooch-only colored HA-coated stems, which happen to be the anterior approach friendly stems, seem to be really decreasing the rates of periprosthetic fractures. So I actually think that if we can do one thing, we should make sure that we all choose the right stems, know the cement when we need to, and know the cable when we need to. So, because that complication can be essentially prevented. With respect to dislocations, I think again, the rates are so low right now. And then now we're just finding out the final details, which is, hey, if you have somebody who's high risk and they have a abnormal hip-spine relationship, should you use enabling technologies? Should you use larger ceramic femoral heads? Should you use dual mobility components? Or maybe it's just the approach. And again, the rates are so low, but that's the one thing we're all still chasing, that perfection. So I think these are probably the top 3 things. About the revisions to the front, it's interesting. That's where I'm going to challenge the anterior approach surgeons. I think that most of the advantages of the anterior approach are in the early recovery. Now, when we're talking about these big revisions, cup cages, a custom tri-flange, all that stuff, I think you lose those advantages through the anterior approach for a pretty big dissection. So I think this is where still don't be a one-trick pony. Be able to do both approaches when necessary. If you can, don't feel the pressure. I think the pressure to do the anterior approach for a primary hip, I got it, and I was influenced by it. To feel the pressure to do revisions to the front, I mean, show me the data one day, maybe, but sometimes the posterior approach is still the winner, especially in these tough, complex cases. I think it's just, again, naturally more extensile, and I don't know, my opinion.
Yeah, I was going to say, Mike, I think you raise a good point. So we just actually finished a conversation with a group of revision surgeons talking about doing revision anterior approach. And I would say about half the surgeons incorporate some posterior approach in their revisions and half don't. And that could be a product of the types of revisions that they're seeing or other factors, but there were some anatomic factors that would push one surgeon to go, for instance, on a posterior approach versus an anterior approach. But there was a common theme that they all raised as far as how they felt that anterior approach in a revision scenario would continue to benefit or potentially even outperform posterior approach, which is in the reliability of the placement of the components. So in being able to reliably restore hip center, reliably restore leg length and offset, and all of the anatomic restoration that we aim for in anterior approach is very much facilitated by the nature of anterior approach surgery being able to be done under guidance of fluoroscopy. Now, I think it's just like we learned with the development of anterior approach. It's good that there are people out there who are taking those chances and pushing those boundaries and learning those things for us. And we'll hope that the dissemination of the education, makes us all better surgeons in the end. Once we have the data to identify what are the best ways to go about it. But I think that's a really good point, is making a surgeon a well-rounded surgeon, and being able to approach the hip from whatever direction the hip needs to be approached. I do have a one additional question for you, Alex. Tell me a little bit about, when I talk to people, I refer to this as the fit check. Give me a little bit about your fit check. So for anterior approach, you mentioned using the Hana table, and you mentioned fluoroscopy. Tell me a little bit about what your standard anterior approach setup is.
Definitely, Joe. Before I go to that, I am going to just go back for 1 second just to highlight something you and Michael were talking about, which is, with all the modern day training of anterior approach, I think there is value of surgeons to learn it, do courses, and even if they don't convert their practice to anterior hip approach, I think there still is value. I think by seeing the anatomy, seeing the approach, as Michael said, when you first start, things are upside down and backwards, but I think that's a good thing as a hip surgeon. I think it's good to understand the anatomy from a different angle and a different place. And so I've had other colleagues who go back to their posterior approaches after trainings, but they say they appreciate learning something different. And I think that highlights what you just said about revision surgery as well. I think one of those benefits are learning how to do those complex revisions from the front, help you appreciate and just make you a better overall surgeon. So just wanted to follow up on your comment.
One thing to say that I still keep the posterior approach as a part of my practice. There are cases where I love showing the resonance. I'm like, really, do you guys think we should do this to the front? And it's it's people with the anatomy that just would make the anterior approach so challenging. And we all know who we're talking about. We're talking about these big dudes with huge beer bellies, and they have these like skinny little thighs, right? And sure, you can do it to the front, but you'll be fighting that belly the entire time. And if you do it through the back, it's significantly easier. Any conversion cases, previous hardware, cases that you just, abnormal anatomy, you're worried. So again, I think we should never be one-trick ponies in orthopedics. And that's probably been my biggest message, I think, to the community, both in the trauma and the arthroplasty world. Just like we fix a femur, you know how to nail and you know how to plate. Sometimes you have to know how to do both. When you put in a toe hip, you need to be able to cement and you need to be able to press fit. And when you do an approach, you need to be able to do at least one other approach for these complex cases. And
So
keep
one of
it. Sorry. I'm
Go
saying
ahead.
I think we should keep it. And some people say I've gone all in 100%. I'm like, okay, fine. But why not maintain that previous skill set that you're good at?
This episode of the AHF Podcast is brought to you by Mizuho OSI. The Hana table has revolutionized how I perform anterior approach hip replacements. The precision and control it offers are unmatched, giving my patients quicker recovery times and better outcomes. Orthopedic surgery is always evolving, and tools like the Hana orthopedic table are what pushes this field forward. We're talking about a solution designed by surgeons for surgeons. Engineered specifically for anterior approach hip arthroplasty, Hana optimizes every step of the procedure. No muscle detachment, unparalleled radiolucency, superior access. If you want to deliver the full benefits of this minimally invasive approach for your patients, you need to do it on the Hana. You can just tell every detail that went into the Hana has been meticulously refined for hip procedures. Mizuho OSI is a proud founding sponsor of the Anterior Hip Foundation, committed to driving innovation, education, and advancing patient care. Join your peers at the Anterior Hip Foundation annual meeting to see how Hana can help you achieve outstanding patient outcomes. And now, back to our podcast.
The question that I had posed to Alex, I'll now pose kind of to both of you guys, which is, what does your anterior approach setup look like normally in your hospital? Are you using the Hana table? Are you using a standard table? Are you using fluoroscopy? Is there any enabling technologies that they're using on a regular basis? Just give me a rundown. And Alex, why don't we start with you?
So for our setup, Joe, we do use the Hana table. Certainly, we like how easy it is to use, how consistent it is for positioning. Certainly with posterior approach, we're all familiar with the person on the opposite side of the table and how variable their help can be when they're trying to move that leg. So having a Hana table that will consistently position the femur where we want it is definitely ideal, and not going to give that up, even though people can do it just fine off table as well. A C-arm, of course, we're highly favorable for, as we've talked about today, all the advantages of it. So definitely not giving that up either. And we do use OrthoGrid AI technology. So we did have our reps using the pen and doing outlines, and that worked just fine. But then printer paper went away. So we had to figure out some sort of technology. And the AI and these current technologies are so fast and reproducible. It gives us great information. So we've been very happy with how that has worked for us. And I've started using some of the automated impactors as well. I didn't think I would. I was resisting it. I wanted to think I was still young, and that was really only for the older guys with rotator cuff problems. But I've actually seen some potential benefits of it, so I've been using that as well.
Alex, it's amazing how similar we are. It's funny. I keep a tab with myself of what I was wrong about, what I'm right about. I'll give you an example. I thought that outpatient surgery was a fad. There's no way it's going to be where we're all doing. And I was clearly wrong. It's amazing how many patients go home the same day. I also thought the automated impactor was just like whatever, just for Americans that love guns. Like, there's no way we need this, And clearly, people really, really like it. And once you get used to it, it just makes the operation a bit more fun. So I use a very similar setup. I use the Hana table. I use a C-arm. It's my favorite advantage of the anterior approach. And I use a anterior friendly implants. And that's pretty much the basic setup. One of the things that I do think about is the hip spine relationship. I used to really say, until somebody figures it out, I'm not going to get involved. Like, let somebody figure it out, and then we'll tackle it. But now with the enabling technology, it's actually easy to figure out. We have all the tools right now. You just have to get a couple extra x-rays. And with those x-rays, we can all start to figure out what's the ideal personalized cup position for that patient. So for my primary basic vanilla cases, I do not use it. But when I do see something that's a bit more complex, where you look at those x-rays and you say, wow, that's way too much of an inlet or an outlet view, or you see fusion of the spine, I wanted to see whether we should get a different cup position, and I use a robot navigation tool that I think definitely allows you to even improve your accuracy even more. The idea behind that is that, in theory, with this technology, we can get rid of radiation. So I still have one more phase of learning, which is eliminating my favorite tool, which kind of sucks. But in theory, we may be able to do that.
What pearls do you have for maximizing your time and your education throughout the process of adopting anterior approach? And for instance, with a surgeon visitation, how do you maximize your time?
I think what was eye-opening for me, Joe, really was attending that Anterior Hip Foundation meeting. And I'm saying it truly, compared to all the other meetings we go to, it really is one that is unique in terms of everyone there loves anterior hip surgery. They love helping each other, love teaching. It's not argumentative at all. You don't see people who are challenging each other unless they're trying to help each other. So there's no animosity. That's really what's great about it. There's some other meetings where it is difficult. People want to show, poor outcomes or show the negative effects of other new technologies or techniques. But really, the Anterior Foundation is very supportive, even when I was the only posterior hip surgeon in the room. And I remember that very fondly. So I think taking advantage of meetings like that, I think getting into the anterior hip community and knowing your peers, get to know your peers. They are all incredibly friendly and helpful. I think that helps you in your journey, not just when you're beginning, but when you're getting better or when you're starting to do revisions or when you're in your 10th year of practice. I think there's still huge benefit to learning from your peers. You don't want to operate in a bubble. You don't want to try to figure things out for yourself. There's so many people out there willing to help. And that's why I can't wait to come to the meeting you're running in Nashville in June. That's going to be another exciting meeting, and each year is different and even better.
We're looking forward to having you. Michael, how about you?
Yeah, I agree. Again, I think that the community is really supportive. I would say it's a 5-step process. If you're really considering making that transition, I would say go to one of the courses, and they're usually industry-sponsored courses. I actually think you should go to 2 courses. Go to one, see how Company X does it, take a break, see how Company Y does it. Then ask yourself, do I still want to do it? If that's the case, then you should go see another surgeon do it live in their OR with their setup. Go see how they do 4 or 5 hips. Then find a surgeon to come back with you and be there around if you don't have somebody around for the first day when you're doing it. And then see how those patients do. Reflect on it. Don't switch 100% up. See how you do, and then reassess. And if then you think, you know what, I'm ready, then you dive all in.
Well, gentlemen, thank you both for talking to me today, for sharing your stories. I really appreciate hearing it. And as you're both, I consider good friends, I appreciate just the opportunity to see you and talk to you.
If you're a mid-career surgeon looking to add anterior approach hip replacement to your practice, we would love to hear from you. Drop us a comment below and tell us your story. Or maybe you have a story to tell about your own adoption of anterior approach in your practice. Leave it in the comments to share with others. Thank you for listening to this episode of the AHF Podcast. Remember to like and subscribe so we can reach a wider audience. If you have an idea for a topic, leave it in the comments. Remember, you can find us in audio podcast form in your favorite podcast app, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. New episodes of the AHF Podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy and healthy.